and Dr. Mohit Saran as chairperson. Dr. Amitesh is Associate Professor in the Department of Medicine, UCMS and GTB hospitals. Dr. Suri is a pathologist running his own center, and Dr. Mohit is associated with Rosewood Hospital at Nazafgarh.
Good afternoon, everybody. I take great pleasure in introducing Dr. J.K. Sharma, who is a medical director and senior consultant of Central Delhi Diabetes Center, senior consultant at Sir Gangaram Hospital, Sir Gangaram Colmet Hospital, Fortis Heart Care Institute and Research Center. He is practicing internal medicine since 29 years, holding many posts. He is a founder secretary general of Innovative Physician Forum, Vice President, Geriatric Society of India, Joint Secretary, RSSDI Delhi Chapter, Executive Committee Member of API Delhi State Chapter, Executive Committee Member, Delhi Diabetic Forum, Member of International Committee of ACE 2016-2017.
Thank you, Dr. Mohit. Thank you. Thank you very much for the nice words. I don't want to come in between to listen to the two legendary speakers from abroad, and I am extremely happy to welcome each one of you, being the organizing secretary of the conference and secretary general of the IPF, and also on behalf of American College of Physicians India chapter. And good afternoon, everybody. The topic which has been put upon me, I'll say put upon me because I was saying that let me organize the conference and let me not be the speaker. But my scientific committee, they said, no, you have to speak. And the topic given was vector-borne disease. And the information which I gathered from the net, from the textbooks, from my friends, the pathologists, the physicians, and everybody who have been looking after these. So I'll hurriedly go through this, what vector-borne diseases are. And there is nothing to disclose in this. We all know that the vector-borne diseases, they are the illnesses caused by pathogens and parasites in the human population, account for more than 17% of all infection diseases and more than 1 million deaths annually. More than 2.5 billion people in over 100 countries, so not only in India, all over the globe. Malaria causes more than 400,000 deaths every year globally. And other diseases such as Chagas disease, leishmaniasis and schistosomiasis, they also affect. But the important thing is that many of these diseases are preventable through informed protective measures. And the main vectors we know, they are the living organisms that transmit the infection diseases between humans and from animals to humans. They are the blood-sucking insects. They are mosquitoes are the best known disease vector. The others include the ticks, flies, sandflies, fleas, triatomine bugs, and some freshwater aquatic snails as well. And the main vectors, mosquitoes, if you take the Aedes, Anopheles, and the Culex. Aedes, the chikungunya, dengue, and Zika, and other yellow fever and all that. Anopheles, malaria, and Culex, Japanese encephalitis, lymphatic filariasis, West Nile fever, and if other are sandflies, ticks, and if we keep on talking about these, then I think we'll need one day. So I'll touch upon dengue, chikungunya, and something about Zika. The epidemiology of dengue is most rapidly spreading mosquito-borne viral disease in the world. Incidence has increased to 30-fold and increasing geographic expansion to the new countries and from urban to rural settings. 50 million dengue infections are annually. The WHO estimates that 2.5 billion people, over 40% of the world population, they are at the risk of dengue infection. And there is a substantial death also because of this and hospitalization as well. This we all know, the dengue virus, it is a genus flavivirus from the family of flavivirid single-stranded RNA with 4 serotypes, then 1 to 4. And the vector profile is Aedes mosquito, which is tropical and subtropical species. Incubation period is from to 10 days. Primary infection induces the lifelong immunity to the infecting serotype. But protection from different serotypes within 2 to 3 months of primary infection, and there is no long-term cross protective immunity. The replication and transmission, if you see the blood meal, then there is a viral replication leading to the WBC and lymphatic infiltration and then released into the circulation. The extensive incubation is from 8 to 12 days, and the female mosquito, they ingest the infected blood, and then the virus replicates in the midgut and remains there and replicates in the salivary gland as well. If you see, there are three phases: febrile, critical phase and the recovery phase, but previously it was classified as grade 1 to 4. There is undifferentiated fever, dengue fever and DHF, so they all has been classified earlier. These are the various grades, but now we don't follow these grades. This is the dengue warning signs with severe plasma leakage, severe hemorrhage and severe organ impairment, and these are the various criteria for dengue. I will focus much upon the treatment part. So the clinical management remains febrile phase, critical phase and the recovery phase. There is sudden onset of high grade fever which lasts from 2 to 7 days with facial flushing, skin erythema, generalized body ache, myalgia and arthralgia, headache, sore throat, injected pharynx and conjunctival injection, anorexia, nausea and vomiting. So a good history taking and a good clinical examination is very important. Now this is the tonic test. So if there is tonic test positive, that increases the probability of dengue, and I suppose each one of us know the tonic test. We tie up the cuff at a pressure of mean pressure of systolic and diastolic pressure for 5 minutes, and then we release it for 2 minutes, and then we measure the petechids in the 1 square inch of the area. If they are more than 10, then it is positive. And then there may be hemorrhagic manifestations, and we look at the liver that is enlarged and tender liver. So earliest abnormality is the progressive decrease in the total WBC counts, white cell counts. Temperature drop in the critical phase, the temperature drops from to 37.5 to 38 degrees in day 3 to 7. If there is increase in the capillary permeability with increasing hematocrit level, the important is hematocrit level, important is not the platelet levels. Significant plasma leakage that lasts for 24 to 48 hours in the critical phase, and there is progressive leukopenia followed by rapid decrease in the platelet precedes plasma leakage. If the increase in capillary permeability is less, then that is a sign of improvement. If it is increase in the capillary permeability is more, than there is pleural effusion and ascites, and the degree of increase above the baseline hematocrit reflects the severity of the plasma leakage. In conditions of shock, critical volume of the plasma is lost, temperature may be subnormal, and if there is a prolonged shock, then organ hypoperfusion, organ impairment, metabolic acidosis and DIC, disseminated intravascular coagulation leading to severe hemorrhage, severe hepatitis, encephalitis or myocarditis. What happens in the recovery phase? There is gradual reabsorption of the extravascular compartment fluid in the next 2 to 3 days. There is general well-being improves, appetite returns, GI symptoms abate, hemodynamic status of the patient stabilizes and diuresis ensues. And if there is rash, then the type of rash is eyes of white in the sea of red, that is typical of these rashes. Hematocrit stabilizes or may be lower due to dilutional effect of the reabsorbed fluid. WBC starts to rise, recovery of the platelet counts occurs later. And this is the course of the dengue illness, where we see during the days of the illness, the temperature, the potential clinical issues, laboratory changes, serology and virology, and course of the dengue illness has been shown into this. Now, how to approach the management? The primary and secondary levels healthcare facilities are responsible for the emergency or the ambulatory trials, assessment and treatment. Trials is the process of rapidly screening patients soon after their arrival in the hospital or health facilities in order to identify those with the severe dengue with warning signs and non-urgent cases, and this is the stepwise approach. Coming to the management, disease notification is important. Here in our country as well, the disease notification is important. Management decisions depending on the clinical manifestations and other circumstances may be sent home, or they may be referred for hospital management, and they may require emergency treatment and urgent referral as well. In the referral centers, receiving severely ill dengue patients must be able to give prompt attention to the referred cases. Now, criteria for transfer, again, early presentation with shock, severe plasma leakage and or shock, undetectable pulse and blood pressure, severe bleeding, fluid overload, organ impairment such as hepatic damage, cardiomyopathy or encephalopathy and encephalitis and other unusual complications. With all these criteria, we must not stick with the patient. Patient should be referred to a tertiary care hospital where all the facilities are available and the disease should be notified. Now, in three groups, Group A, Group B and Group 3, we have to take the management decisions. In Group A, it may be sent home. If tolerates adequate volume of the oral fluids and pass urine at least once in every 6 hours and there are no warning signs, then patient can be sent home. In Group B, referred for in-hospital management with warning signs, coexisting conditions and with certain social circumstances. And in Group C, which require emergency treatment and urgent referral in cases of severe dengue in critical phase. Now, these are the various action plans, but I will stick more on the Group B. Group B action plan, reference hematologic before fluid therapy, isotonic solutions 5 to 7 ml per kilogram per hour for 1 to 2 hours, then reduced to 3 to 5 ml for next 2 to 4 hours and then 2 to 3 ml or less according to the clinical response of the person. And reassess, hematocrit remains the same or rise normal only minimally, then make it 2 to 3 ml per kg per hour for another 2 to 4 hours and worsening vital signs and rising hematocrit rising, then give minimum intravenous fluid volume, maintain good perfusion and urine output of about 0.5 ml per kg per hour. Intravenous fluids are usually needed for only 24 to 48 hours. Reduce the intravenous fluids gradually when the rate of plasma leakage decreases towards the end of the critical phase. Monitor vital signs, urine output, hematocrit and organ functions. Encourage oral fluids. If not tolerated, then start IV fluid. Give the minimum volume required and intravenous fluids are usually needed. Then there is close monitoring. In Group C, the action plan is admit to a hospital with access to intensive care facilities and blood transfusion. Plasma losses should be replaced immediately and rapidly with isotonic crystalloid solution or in the case of hypovolemic shock with the colloid solutions. Blood transfusion with suspected or severe bleeding. Judicious intravenous fluid resuscitation is the sole intervention required. Now, goal of fluid resuscitation, improving the central and the peripheral circulation, decreasing tachycardia, improving blood pressure, warm and pink extremities and capillary refill time should be less than 2 seconds. Improving end organ function, that is stable consist levels, urine output should be more than 0.5 ml per kg per hour and there should be decreasing metabolic acidosis. Now, if you see this, we grade the severity of the dengue infection, grades 1, 2 and 3, 4, but this I have already told you, now we don't follow this. And if the volume replacement flow chart for patients with dengue hemorrhagic fever grade 1 and 2, then hemorrhagic bleeding tendencies, thrombocytopenia, then initiate IV therapy. If improves, then IV therapy by crystalloid, earlier with crystalloid solution for 1 to 2 hours. And further improvement, then discontinue IV therapy. If there is no improvement, then increase the IV. If improvement, then reduce it to 6 ml per kg. Or if there is no improvement, unstable vital signs, then hematocrit rises or hematocrit falls, depending on then we give the colloid dextran or blood transfusion. And volume replacement flow chart for patients with DHF grade 3 and 4, which is the unstable vital signs, immediate rapid volume replacement. If there is improvement, then IV therapy by crystalloid. If no improvement, then oxygen. Further improvement, then discontinue the IV therapy. If there is no improvement then we give oxygen and see for the hematocrit rises or hematocrit falls, depending on then we give the IV colloid or the blood transfusion. Now, what are the treatment of the hemorrhagic complications? Patient at risk of major bleeding are those who prolonged refractory shock, hypotensive shock, or renal or liver failure and or severe and persistent metabolic acidosis, given non-steroidal anti-inflammatory agents, pre-existing peptic ulcer disease and anticoagulant therapy and any form of the trauma. These are the patient at risk of major bleeding. Blood transfusion is life-saving and should be given as soon as severe bleeding is suspected or recognized. Do not wait for the hematocrit to drop too low before deciding on the blood transfusion. and look for the risk of volume overload. Blood transfusion, if the bleeding 5 to 10 ml per kg of PRBC or 10 to 20 ml per kg of the FPW, repeat if the further blood loss or no rise of the hematocrit after transfusion. There is little evidence to support transfusion of the platelet concentrate and the FFP. Massive bleeding not managed by FWB or PRPC then may exacerbate the fluid overload, and in cases where preventive platelet transfusion is given, the prolongation of hospitalization is increased. We have to look for the fluid overload, and then how to discharge the patient. Clinically, no fever for 48 hours, improvement in clinical signs, clinic state and laboratory, increasing field of platelet count and stable hematocrit without the intravenous fluids on oral medications. Now coming to the another one, which is the chikungunya. It's again a virus that is transmitted from human to human mainly by the infected Aedes albopictus and Aedes aegypti mosquitoes, and it causes sudden onset of high fever, severe joint pains, muscle and headache, as no vaccine or medication is currently available. To prevent or cure this infection, control of chikungunya involves vector control measures and encouraging people to avoid the mosquito bites. These are the symptoms which are practically common. Symptom onset of high grade fever, headache, back pain, myalgia and arthralgia, and they appear average 4 to 7 days. Again, the vector is spread among humans mainly by the bites of the infected Aedes mosquitoes, and these mosquito types are characterized by white strips on their black bodies and legs. And this is the epidemiology, and if you look our India, Africa, Southeast Asia, Indian subcontinent and island of the Indian Ocean. What are the preventive measures? When staying in affected areas, wear long sleeved shirts, use mosquito repellents, coils or other devices, and if possible sleep under the bed nets. Set the air conditioning to a low temperature at night. Pregnant women, children under 12 years of age, old people, people with immune disorders or severe chronic injuries should be given personalized advice. Now what should I do if I suspect my patient has chikungunya? Clinical criteria: acute onset of fever and severe incapacitating arthralgia not explained by other medical conditions. Epidemiological criteria: residing or having visited epidemic areas, and lab criteria are by virus isolation, presence of viral RNA or RT-PCR, presence of virus-specific IgM or IgG antibodies in single serum sample collected, and seroconversion to virus-specific antibodies in samples collected at least one of the 3 weeks. Now, this is the algorithm for assessment of the suspected chikungunya case. Coming to the treatment part, in the absence of treatment for chikungunya fever, focus is set on symptomatic treatment only, non-steroidal anti-inflammatory, non-salicylate analgesics, surveillance of the patient for complications and prevention of the further transmission. The complications, they include the GI complications, cardiovascular decompensation and meningoencephalitis. Fatalities have been reported mainly in aged patients or where the patient immune system was weakened by the underlying condition. Community measures for healthcare practitioner area where the vector is present: control the vector, like the vector lives in a number of different habitats, and it is important that every citizen takes action to avoid water gathering in containers in the vicinity of they have. Coming to Zika, this is the recent one. Single strand RNA virus, genus of the again the flavivirus, family of the Flaviviridae, closely related to dengue, yellow fever, Japanese encephalitis and West Nile viruses. Primarily transmitted through the bite of an infected Aedes species mosquito, and before 2015, Zika outbreaks occurred in Africa, Southeast Asia and the Pacific Islands. Currently is a rise in many countries and territories. For the most recent case control of the US, we can visit this website, and the transmission is bite from an infected mosquito. Maternal fetal transmission, which is very, very important, periconceptional or intrauterine or perinatal, sexual transmission from an infected person to his or her partners, and laboratory exposure. Now this is what we have seen in India, 3 cases of Zika virus infection, and it appeared in the news and in the literature that on 15th May 2017, the Ministry of Health and Family Welfare, Government of India, reported 3 laboratory confirmed cases of Zika in Bapu Nagar area of Ahmedabad district, Gujarat, And this is the description of the 3 cases, but these are the only 3 cases which have yet been described. The clinical, if you compare the clinical features of the 3 viral diseases, Zika, dengue and chikungunya, we can see the fever is less in Zika as compared to dengue and chikungunya. Rashes are more with Zika and chikungunya. Conjunctivitis is important in Zika, arthralgia more in chikungunya, and with troubles to the patients for maybe for more than 1 year. Headache specific in dengue and chikungunya. Hemorrhage is more with dengue. And if you see the comparative regarding the carrier, the transmission, the most common symptoms, headache is very important, arthralgia is very important in cases of chikungunya, and conjunctival congestion is very important in cases of Zika. Now, pregnant women, the elderly, infant, small children, and anyone with a medical condition or weakened immune system may be at increased risk of developing symptoms from the mosquito-borne diseases. The possible complications, according to the CDC, in addition to the microcephaly, other neurological health problems have been detected in babies infected with Zika, including eye defect, hearing loss, and impaired growth. So, perinatal or periconceptual periconceptual, if there is a symptom, then diagnosis is very important. Treatment, there is no vaccine to prevent or medicine to treat these diseases. Treat the symptoms as you would a cold or flu with plenty of rest and fluid, and over-the-counter pain and fever reducers, especially the NSAIDs and salicylates, they should not be used. We can use the paracetamol, or we can use the other non-steroidal. But specifically non-steroidal should not be used. The prevention, again, it remains same practically for all the 3 diseases, and we have to specially see if the person has traveled. Thank you very much.
This lecture, due to paucity of time, we won't be taking any questions. The questions can be taken on the lunch time. Thank you very much.
Thank you, sir. Now I would request our chairperson to please present a memento to Dr. J.K. Sharma. Now I will request Dr. Anil Manchanda to please hand over to present a memento to our chairpersons.
I just want to make one disclaimer that I have nothing, absolutely nothing against diabetes, but this Innovative Physicians Forum was becoming absolutely diabetes oriented. So that was the reason that in this particular conference we had taken lot of subjects other than diabetes, like rheumatoid arthritis, then congestive heart failure, then hematology, and last but not the least, the vector-borne. And I had no other choice but to choose J.K. Sharma for this topic. I think he may excuse me for this. Thank you.
Thank you, sir. So for the next session by Dr. Paresh Dandona on role of SGLT2 inhibitors in type 1 diabetes, I would like to invite chairpersons Dr. Rajiv Chawla, Dr. Shalini Jaggi, and Dr. Girish Khurana. Dr. Rajiv Chawla is a senior diabetologist and director at North Delhi Diabetes Center. Dr. Shalini Jaggi is consultant diabetologist and head at Dr. Mohan's Diabetes Institute. And Dr. Girish Khurana is consultant physician and diabetologist.
Good morning, everybody. It's a great pleasure to invite the next speaker, Professor Paresh Dandona. In fact, it was very difficult to get him here. Fortunately, we had one meeting about 7 days ago at Pune, and we requested him and somehow hooked him for this session. Dr. Paresh Dandona, who is Professor and Head Distinguished Professor of Medicine and Endocrinology at SUNY, that is State University of New York, and Director Diabetes and Endocrinology Center, Buffalo. His specialty interests have been endocrinology, diabetes and metabolism, has huge number of publications, more than 300 to his credit, has been President-elect Diabetes, American Diabetes Association, he has been member Endocrine Society, AHA, North American Menopause Society, has huge number of awards and honors. If I go on, probably this list will never be ending. In one word, I can summarize. I had an opportunity to work with him about 15 years ago. I did observership with him and has been a mentor and teacher for me. But he is a very, very innovative scientist, man who thinks absolutely original, who thinks absolutely unconventional. I remember one of his earliest publication came on scorpion venom, when he said that if it induces inflammation, probably insulin can be an anti-inflammatory drug. When the whole world was talking about that insulin probably once given from exogenous routes will have lot many side effects, weight gain and maybe increased cardiosomatology, he said that insulin has anti-inflammatory action. And today when the whole world is talking about type 1 and we are talking about SGLT2 and GLP-1 like drugs, that these are probably being used off-label and should not be used in type 1. He is again very, very innovative about that, and he says that probably these drugs could be wonderful in practice of type 1 also. So his topic today is type 1, what is in future due for type 1 diabetic patient. Professor Dandona, please.
Speakers, chairpersons, and the chairpersons are Dr. B.M. Makkar, Dr. Meena Chabda. I don't think Dr. B.M. Makkar and Dr. Meena Chabda require an introduction. Dr. Meena Chabda is the chairperson of our innovative physician forum as well. And Dr. Makkar is well known to all of us, not only India, globally. And I'll also join, I'll have the honor to join the two chairpersons to chair this session of Professor Sundar Mudaliar. And Dr. Makkar will be introducing to Dr. Mudaliar. Sir, please.
अरे खुल गया ना डॉक्टर डंडोना का नो नो मे बी
Good afternoon, friends. At the outset, I would like to thank Innovative Physician Forum and especially Dr. Sharma, Dr. O.P. Sharma, Dr. J.K. Sharma and Dr. Meena, the key persons in the organization for giving me this opportunity to be here and chair this very important session.
And it is indeed a privilege to be chairing a session for a legendary person in the field of diabetes like Dr. Sundar Mudaliar. Dr. Sundar Mudaliar is, I am sure you have heard him earlier, he has been on a few occasions in Delhi. He is professor at Veteran Affairs Institute, San Diego, and has contributed in a lot in the field of diabetes, and one of his latest works is the understanding of mechanisms of action involved in the CV benefits from SGLT2 inhibitors, and that's what he is going to talk. Dr. Mudaliar currently holds the post of clinical professor at University of California, San Diego, and is director of diabetes clinic and special diagnostic and treatment unit at VA San Diego. He is also investigator in the NIH Diabetes Prevention Program, NIH GRADE study, and NIH EDIC, which is DCCT follow-up study. So, pleasure to welcome you here, sir.
Okay, it's indeed a pleasure and an honor for me to present here. I'd like to thank the organizers for inviting me, and first of all, my conflict of interest disclosures are up there. There are many definitions of diabetes, but somehow I like this one from Miles Fisher, who is a diabetologist in Glasgow. And he says diabetes actually is a state of premature cardiovascular death, which is associated with chronic hyperglycemia and may also be associated with blindness and renal failure. So in the setting of this, when in September 2015, the EMPEREG outcome study was presented at the European Diabetes Meeting, and this was a paper in the New England Journal of Medicine, it was kind of like almost a game changer. Till this time, we did not have any medication which could affect cardiovascular mortality. Truly, I mean, we talk about metformin and all that, but if you lower the glucose or you use any particular agent, we didn't have a drug that could do this until this drug. And the primary MACE outcome, which is non-fatal MI, non-fatal stroke and cardiovascular death, there was a relative risk reduction of 14%, which is quite impressive. Given that these people are being treated to standard with blood pressure, with 80% are on ACEs and ARBs, 80% are taking statins and all that. But if you look into the MACE outcomes, there was no decrease in any of the classic atherothrombotic or atherosclerotic events. We usually think of, okay, MI and stroke. Nothing happened with these two. In fact, there was a trend towards more stroke. Although recently, just last month, they published data from in the Stroke magazine that the stroke actually was not increased. It occurred 90 days after stopping the drug. So that has been revived. But be that as it may, so there is a reduction in the primary MACE outcome, no change in MI, no change in stroke, and the benefit was driven entirely by a 38% relative risk reduction in cardiovascular death. Even in the original 4S study with the simvastatin, it was about a 32% reduction in cardiovascular death. So actually, when the results came out, it was very puzzling to me. And the question I asked myself was very naive. There is a reduction in cardiovascular death. So they're dying less. But they're not dying of it's not an MI, it's not a stroke. So what are they not dying of? It's a silly question, but it didn't make sense to me. And then I said, maybe it's got nothing to do with stroke, it's got nothing to do with MI, it's something to do with myocardial function. And we've heard about myocardial function before. And if you improve myocardial function, potentially less arrhythmias, less sudden death, and also less heart failure, leading to less hospitalization for heart failure. And as we heard before, this is a very powerful predictor of death. And in the EMPEREG outcome study, there was a 35% relative risk reduction in hospitalization for heart failure. Heart failure has been forgotten. A good friend of mine, David Bell, he says, heart failure is the frequent, forgotten, and often fatal complication of diabetes. We heard this before. This is from older data. About 1 in 5 patients above the age of 65. And this is more troubling. Patients with diabetes and heart failure, median survival is 4 years. The survival in many cancers is better than that if you have diabetes and heart failure and you've been admitted for the heart failure. And if you looked into the EMPA-REG, the time to first hospitalization for either heart failure or death, because that drove it, hazard ratio 0.66, that's a relative risk reduction of 34%. And it starts right in the beginning. Within days almost there are changes and you can see the line splitting. So what is doing this? I mean, statins, blood pressure drugs and all that, they take about months to years. It cannot happen immediately. First, of course, is it too good to be true? You know, the classic type A error. Is it a false alarm? But then recently, just last month, at the American Diabetes, they presented the Canvas results. And what did that show? So I just put them both together. EMPA-REG is in red, Canvas is in blue. And you can see the MACE outcome of non-fatal MI stroke. Look at the blue for Canvas, look at the red for EMPA-REG. Almost superimposable. CV death, there's a difference over here. As you can see, there's more CV death reduction with empagliflozin compared to Cana. Numbers are smaller over here. And of course, I mean, numbers were not smaller. It was a low-risk population. In EMPA-REG, everybody had to have a CV event. Whereas in EMPA-REG, it was a very complicated statistical exercise. They combined Canvas, Canvas-R. Only 2/3 of the people had cardiovascular death. But look at the others. Non-fatal stroke also kind of tending to go over the line over there. Hospitalization for heart failure, almost bang on. Both of them are almost superimposable. And these are the renal outcomes also looking the same. So it's kind of going in the right direction. But the question, of course, is what is driving the cardiovascular? And I'm not going to talk about the renal, and I think it's the same mechanism. So people have postulated many mechanisms by which SGLT2 inhibition will protect both the heart and the kidney. Well, these drugs lower blood glucose by a glucosuric effect, causes a negative calorie balance, less body weight, less inflammation. A1C is down, less inflammation, less toxicity. There's a uricosuric effect with these drugs. Plasma uric acid going down it's part of that insulin resistance cycle, and that can also cause the benefits. On the other hand, apart from the glucose, the metabolic effects, we have the hemodynamic effects, mainly due to natriuresis. Less blood pressure, less arterial stiffness, lower plasma volume, about 7%. So that's less myocardial stretch, less preload on the heart. Then there is the tubular glomerular reflux, which is increased, and that's what the ACEs and ARBs do, and there's less afferent arterial constriction. But if you look in the EMPA-REG, the body weight difference was only about a kilo and a half, and no weight loss study has shown this so far. A1C 0.3, that cannot account for so much difference. Blood pressure about 3 millimeters, and there may be studies, but no blood pressure drug has caused this benefit within such a short period of time. Plasma volume about 7%, but we have not seen it really with diuretics. And lastly, 80% of these people are already on ACEs and ARBs. So it's possible that if you put all these mechanisms together, it could contribute to the benefit, but we think that I think we're missing a key mechanism, and that is myocardial and renal tissue hypoxia. So the question is, why should the diabetic heart and the kidney become hypoxic? The heart is full of blood, oxygenated blood. Why is it getting hypoxic? Well, let's look at oxygen consumption in the heart and the kidney. The resting heart is by far and away the largest consumer of oxygen in the body, 8 ml of oxygen per minute per 100 gram of tissue. The kidney is not far behind, 5 ml of oxygen per minute per 100 gram of tissue. Because think about it, the heart beats about more than 100,000 times each day. Beat to beat, it needs energy. It's consuming oxygen all the time. The brain is there, 3 ml of oxygen per minute per 100 gram of tissue. Now, some facts about myocardial fuel metabolism. The heart has to make ATP continuously. It can store maybe 5-6 beats as phosphocreatinine. The heart doesn't have glycogen, any serious stores of glycogen or fat, because the heart is not a storage organ. It has to be lean and keep pumping all the time. And 95% of it has to be oxidative. The non-oxidative pathway with lactate is very inefficient. You just get 2 ATP per cycle, and that's not going to do it. Many factors affected: workload, hormone changes, availability of the substrate. But the heart is classically an omnivore. It will use whatever fuel it is that is available at that time. Mostly it uses fatty acids and glucose, but it can use lactate, pyruvate, ketones, amino acids, because it has to get the fuel and make it all the time. It cannot wait for something to come a minute or two later. Now, if you look at the energy efficiency of these fuel substrates, this is known as the ATP yield per oxygen atom consumed, the so-called PO ratio. This, if you want, you can call it kilometers per liter. You put 1 liter, one car will take you 40 kilometers, one will take you 20. The best fuel is glucose, 2.58 moles of ATP per atom of oxygen consumed. Beta-hydroxybutyrate is very close to it, 2.50 moles. Fatty acid, palmitate in this case, is a good energy source, but it's only 2.33 moles of ATP. Now this is only about 10% less, but beat to beat, minute to minute, it adds up. It's like, a struggling heart, if it is being inefficient, it's getting less mileage, it's going to suffer. So this is what we think happens in the diabetic heart. There is metabolic inflexibility, we know it. There's increased fat oxidation because fat is available in plenty. There's less glucose oxidation, partly because of insulin resistance, and the Randall cycle, fat oxidation suppresses glucose oxidation. Fat is good, it's very energy dense, but it's energy inefficient. Less moles of ATP, more myocardial hypoxia, and paradoxically the diabetic heart is suffering from starvation amidst plenty. Lots of free fatty acids, it's using it, it's inefficient. Lots of glucose, there's hyperglycemia, it cannot use that. And ultimately that leads to a lot of changes, which together has been called an entity of diabetic cardiomyopathy. But the bottom line is this will lead to heart failure. And Stephen Neubauer has written a nice article, and he says the failing heart is like an engine running out of fuel. In this setting, could a change in the fuel substrate help? What about ketones? Now the moment we think of ketones, we think of DKA. We don't want to deal with it. I mean, that's a patient in the ICU. But could ketones be good for us? Why are they there? Phylogenetically, if you trace it back, it goes back about 1 billion years, this fuel over there. So it's very ancient, this fuel. And George Cahill, who's done a lot of work, has called it not just a fuel, he calls it a super fuel because it produces ATP energy much more efficiently. What's the evidence? Well, when you study myocardial fuel metabolism, you have to study a working heart model. You cannot take it out and put it in the dish or anything. And in a working rat heart model, if you add insulin or ketones with 10 millimolar glucose, you can increase myocardial work efficiency, defined as work divided by the energy consumed by about 25%. And the combination of the two increases work efficiency by about 36%. And there's a lot of evidence emerging that the failing heart will depend on ketone bodies as a fuel. It's well known. What about in humans? Well, there's not much studies in humans. This is an old study from Texas in which they were doing cardiac caths for various reasons. They had people with low ejection fractions, 25. They had people with normal ejection fractions. They catheterized the coronary sinus and all that. Bottom line, what they found is that in people who had a low ejection fraction, skeletal muscle ketone body utilization was decreased. Normal extraction of beta-hydroxybutyrate arteriovenous is about 44%. In the skeletal muscle it fell to 22%, and they think that's why people with heart failure, they're very tired, they're very achy. But myocardial fuel ketone body utilization was kept at 44%. So the failing myocardium is still taking all the beta-hydroxybutyrate that it can through that. So in our model, we think there's metabolic inflexibility, more fat oxidation, less glucose oxidation, there's a poor PO ratio, less efficiency, less contractility, more tendency to go towards heart failure, and the heart literally struggles to breathe. If you add an SGLT2 inhibitor, ketone bodies are increased. How much? About its chronic low-grade hyperketonemia, it's about doubled. Normal ketone bodies, if we fast overnight, you look in the urine, there's going to be ketones. There has to be ketones. You haven't eaten overnight 10 to 12 hours, fat is being burnt and you get ketones. And normally it's about 100, 150 micromolar. People on SGLT2, it's doubled to about 500, 600 micromolar. When we talk of DKA, we think of 1,000 micromolar, 1 to 2 or more millimoles, not micromoles over there. And this fuel is not only there, it is being utilized. When beta hydroxybutyrate is being utilized, it suppresses fat oxidation and possibly also glucose oxidation. There's a better PO ratio, better efficiency, better contractility, and less incidence and progression of heart failure. And now the heart can beat better. So I knew I had a time of only 18 minutes, so I had to really shorten my presentation. I have the kidney part of it. I can't show it to you. But the basis of our hypothesis is that when you treat, and in the EMPEREG outcome study, it was empagliflozin, it improves both myocardial and renal fuel energetics and efficiency. Why do I say renal? 80% of renal energy is consumed by the SGLT2 transporter. It is taking sodium and glucose, 80% of energy. And what is the diabetic kidney doing? Unnecessarily it is taking it back. We know in a diabetic kidney they reabsorb more of the glucose. The SGLT2 transporter blocks that futile cycle and can save a lot of energy over there. And there are some mathematical models for that. So once the ketones go up, there's increased ketone body utilization secondary to availability of the ketones and the extraction of the ketones. This provides better energy efficient oxygen consumption and potentially less hypoxic stress on the diabetic heart and the diabetic kidney. Now, this was just a recent review and it's very nice. We're learning more and more about ketone bodies. Beta hydroxybutyrate, we thought it is a starvation response. It turns out it is a signaling metabolite. It signals. And there's lots of studies to show it acts through this NLRP3, the NOD-like protein 3, which it's an inflammasome which plays a major role in inflammation, and the ketone bodies block that pathway. Ketone bodies act through HCAR2, hydroxycarboxylic acid receptor 2, and blocks lipolysis. Turns out HCAR2 is the receptor for nicotinic acid, which we've used for many years. We didn't know how it acts, but it acts through the hydroxycarbolic acid receptor. And just to confuse you a little more, let me tell you this. Beta hydroxybutyrate is traditionally not a ketone body. Ketone body has got the C carbon double bond O. It doesn't have it. Acetoacetate has it, acetone has it. Beta hydroxybutyrate is technically a hydroxycarbolic acid. But that's, by the way, it's kind of grandfathered in as a ketone body. It does all the things. Beta hydroxybutyrate also acts through the FR3, the free fatty acid 3 receptor, lowers the metabolic rate. It acts, and this is one of the most important activities of it, and there's evidence to show that HDAC is the histone deacetylase, and that acts through FOXO3, reduces stress resistance, reduces the left ventricular mass index, because that is what contributes to the diastolic dysfunction, the HFpEF, which diabetics have. When they give these drugs, I didn't have time, I thought I didn't have the time. These drugs within 3 months significantly reduce the left ventricular mass index and improve the early diastolic flow, which is a classic feature in this. And last but not the least, ketone bodies improve longevity. Early studies are there in non-human primates. If you starve up, you reduce calorie load, ketones go up, it improves longevity. The only thing we don't know today is it 1 meal a day? Is it 1 day a week? We don't know that. All we know is that if you reduce calories, you can do it. So ketone bodies have got multiple effects to do that. So before I run out of time and I hear that bell, let me just finish with this. Actually, Malavika Agnimitran was the first play written by Kalidasa. And this is what he said: do not accept anything as good just because it is old. Do not reject anything as useless just because it is new. The wise weigh the substance and decide for themselves. It is the unwise who are led by the opinion of others. So I hope I've given you something. It's a hypothesis. The SGLT2 inhibitors are new drugs. I think we shouldn't let, a lot of people say, oh, don't use it, it causes genital infections, mosquitoes. Yes, every drug has got a side effect. Have I seen lactic acidosis, metformin? Yes, only 3 cases in 30 years, but I use it all the time. Metformin is a good drug. We are learning more and more about these drugs, and we know we should not reject it as useless just because it's new. I think they have great potential, especially in heart failure. We've heard from our cardiologists, it might come in, it's already come into a lot of the other guidelines. If you get a diabetes drug, which is heart failure, that's kind of thinking out of the box. And last but not the least, we had a chance to, write it. We published in Diabetes Care, Can a Shift in Fuel Energetics Explain the Beneficial Cardiorenal Outcomes in the EMPEREG? Actually, the original title which I gave to the paper was The Enigma of the EMPEREG Outcome Study of Fuel Energetics, the Answer. We had 3 reviewers, they all said no, 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 and they made us change it into it. With that, I thank you very much for your attention. Thank you. No, I'm very scared when I hear the word simple.
I'm treating a heart failure patient with diabetes, and I have 3 SGLT2 inhibitors in my inventory: canagliflozin, empagliflozin, and dapagliflozin, which are available in India. How do you choose which one? Because EMPEREG says empagliflozin, Declare says dapagliflozin, and Canvas says canagliflozin. Is this a class effect, or I can prefer one over other?
Okay, I knew it was not a simple question. The first thing is Declare has not been published. It's going to be published in 2018 or 2019 probably. Canvas and EMPEREG have been published. Now, that's is it a class versus a compound? Is there? This is my personal opinion, okay? The heart failure, I think, is a class effect, I think. Okay, there are other differences in these compounds, especially on the bone. Canagliflozin has got 2, it's got a black box warning for osteomyelitis, lower extremity amputations and bone fractures. But DAPA and EMPA don't. They have almost up to 2 years of data, nothing to the bone. And of course, we have this selectivity for 2 versus 1, and EMPA is about 2,000 something to 1, DAPA is next to 1,200 Cana. Does it make a difference? There are SGLT1 transporters present in the heart. I don't know. So which to choose? For me personally, in the US, it depends on what the insurance company pays for, which plan they are on. If you go by evidence-based medicine, so far it's empagliflozin. The Cana data is just out. It's a little clouded because they didn't get, that's another talk in itself. They had Canvas and Canvas R, and they put them together. It was a statistical kind of a thing over there. So to your answer, it is, that's what I said, you have to get the experience and use it. I cannot give you an answer.
Thank you. Thank you.
I think we can't take more questions. We are already running behind schedule. So maybe you can have a chat with Dr. Sundar during the lunch hour. With this, I think we would like to thank Dr. Sundar Mudaliar for taking out time out of busy schedule and being here for this meeting. I would request Dr. O.P. Sharma to present a memento to Dr. Sundar.
So I would request Dr. Sharma
To join.
All of you can, sir, join. Please give a big hand to Dr. Mudalia.
Now
I will request
I
Dr.
invite
O.P. Sharma to
Dr.
please
Dandona to please
give a
come on
memento
the
to Dr.
dais.
Makkar.
And
sir, Dr. Makkar, Dr. J.K. Sharma also. Please give memento for Dr. You have already given? Okay, is it?
I invite the chairpersons for this session, Dr. Chawla, Dr. Shalini and Dr. Girish Khurana. Sir, sorry for the delay.
So finally we got it right, and now I present to you Professor Dandona. Sir, this floor is all yours for next 30 minutes.
Okay, यहाँ लगा दीजिए, just quicker, better. So good afternoon, and I apologize for my allergogenic flash drive, and I didn't realize the little flash drive could drive out the chairman of the meeting and so on, and then cause an upheaval. So hopefully the upheaval is over, but still there may be some chaos in the slides, so please pardon me because we had to concoct something just offhand. So what I'm going to be talking about today is a topic of type 1 diabetes. And type 1 diabetes still remains a major issue. In the last 2 decades, we made tremendous advances in terms of new development in type 2 diabetes, novel drugs and treatments and so on. And I call it now the golden age of, can you hear me at the back? Yes, so because this is causing too much of echo, I thought, while I was listening. So, I call it the golden age of type 2 diabetes. Why? Because of the drugs that are available. And now, with all the drugs that are available, there is no excuse for not having 100% of our type 2 diabetics being controlled perfectly. Unfortunately, that has not been translated into patient care yet. Hopefully, that will happen, and we need to build a bridge. But what is also interesting, and I feel proud to be able to say that using the drugs that were brought out for type 2 diabetes, we were the pioneers in starting up an investigation with these drugs to see if they could be used in type 2 diabetes. What I'm going to be talking about today is an element of those advances. And we are currently, even if I say so in the presence of Sundar, we are the world leaders in type 1 diabetes pharmacological treatment. So I plead with you to pay attention and to challenge whatever novel things that you think are not correct as I go on. So just go on, and we start off with this famous historic picture of Banting and Best in the summer of 1921. So we're close to 100 years now. Another 4 years, and it'll be 100 years with the discovery of insulin. And as you know, Marjorie, the dog, was pancreatectomized and then given extracts of the pancreas. And lo and behold, blood sugars normalized, glycosuria disappeared, and the diabetes was treated. And we thought at that time, of course I was not alive at that time, but people thought at that time that the problem of diabetes had been sorted out. And of course, the results were so impressive. You can see here a cachectic child at the time of no insulin treatment, and within 5 months, how the development takes place. Total transformation. So people thought that the problem of type 1 diabetes was sorted out. But of course, it wasn't. We are still with a majority of type 1 patients who are not under control, and a majority of them are condemned to long-term complications. And if you want to read about the intensity of these complications, you need to read a paper by Lind 2.5 years ago in New England Journal of Medicine, which showed that mortality in the type 1 diabetic, even if the A1C is less than 6.5, is 2.5 times greater than that in the normal population. And if the A1C is greater than 10, it's about 10 times greater. And if you are an end-stage renal failure person with type 1 diabetes, and A1C is high, as I mentioned, your chances of dying are 40 times greater than that in the normal population. So type 1 diabetes remains a major issue, in spite of the dramatic effects. And talking about this drama, the other fascinating fact is that the Nobel Prize, the fastest ever Nobel Prize, was following the discovery of insulin in 1921, because by 1923, the whole world was being treated with insulin of one kind or another, and the drama of improvement was there. So Nobel Prize was given to Banting, and his supervisor, Best, had been missed, but later on the Nobel Prizes were shared, so although Banting and MacLeod got it. And I like to say, actually, this is also funny, so even if it takes away a minute of my time, I'll tell you this story, that Banting was disliked by Professor MacLeod. And professors often don't like cocky young people working in their lab. So MacLeod was away in Scotland, fishing and hunting. And, as you know, when the cat is away, the mice will play. And Banting got on with his hypothesis of the pancreas and insulin. And by the time MacLeod came back from the summer vacation in Scotland, all these experiments had been completed. And eventually, since MacLeod was the supervisor, he got the Nobel Prize to share with Banting. But Collip and Best were eventually sharers of the prize at an informal level. Anyway, be that as it may, the next thing then that I want to talk about is the attempts in recent times of incorporating type 2 diabetic therapies. And this was initial paper on dapagliflozin in type 1 diabetes, a short-term treatment led by Bob Henry here, and Sundar was also a co-author in this, so he's got to be recognized this. So first preliminary study on an SGLT inhibitor over a period of few weeks to see whether the SGLT2 inhibitor produced control. So we'll jump over these slides because the time is short, and this has had to be done temporarily through this file that I had, so I'll just go through that, and then we'll move into the study that we published in 2011, the very first one, in type 1 diabetes with a type 2 drug on liraglutide. And liraglutide, when we used it in type 1 diabetics in that series published 6 years ago now, showed dramatic effects. And you can see the drama here, that a chaotic type 1 diabetic control shown on CGM being sort of tamed by the liraglutide treatment over a period of 6 months. So clearly this drug had a role, and the role was dual. On the one hand, A1C came down, on the other hand, glycemic excursions were tamed tremendously. So a dual role. And why I want to mention this is because till now we have used A1C as our only index of diabetic control. That doesn't tell us anything about the quality of control within that mean glycemic level. And in future, as the CGM facilities become available, we will see that we will be looking at glycemic excursions and the CGM patterns, because especially in the type 1, they are very important. In the type 2 diabetes, which is associated with endogenous insulin secretion still, you do not have the kind of unpredictability that type 1 diabetes has. So here is another CGM that was on the Dexcom. This is Medtronic, and you can see the mountains and the valleys in the top one. And once liraglutide is introduced, you can see the taming of those excursions. And then as you withdraw the liraglutide, the mountains and the valleys reappear. So then, that led to a retrospective study that we published also over a period of 6 months. And again, that showed significant improvements, and I don't want to waste time on it. But the other very interesting point that I want to make here is that on hypertension. And our cardiologist friend here will appreciate this very interesting fact, that In a study in 2007 in type 2 diabetics, we had shown for the first time that the use of exenatide, the first GLP-1 receptor agonist, reduced systolic blood pressure. And that observation was confirmed in this study on liraglutide as well. And you can see a remarkable fall in the systolic blood pressure. Now, this may be unusual, and later studies may show less of an effect, but clearly in those patients who are not on any antihypertensive drugs, this reduction was remarkable. And in those who were on antihypertensive drugs, the magnitude was a little smaller, but still significant, 130 to 119. And nowadays, as a clinician, I find it fascinating that whenever I see in my patients a systolic blood pressure in teens, less than 120, I have a sense that the patient must be on a GLP-1 receptor agonist. Okay, let's leave this and move on to other issues. And this is the retrospective study we published last year, a large randomized control trial published in Diabetes Care last year. And here you see one of the secrets behind, the mechanisms behind the remarkable improvement in diabetic control. And that is the suppression of postprandial glucagon. And this we showed in our study was a dose-dependent phenomenon. So you can see that following a meal, glucagon excursion in the type 1 diabetic is pretty wild. The last thing you want in the postprandial setting is to have glucagon rising, because that will cause the glucose to rise further. And that's one of the flaws with type 1s. You give the liraglutide and you can see a suppression of that. And then free fatty acids also go down remarkably postprandially, and of course glycemic excursions improve, and also a series of follow-ups on this, and you can see the glycemic excursions improving in the type 1 diabetics following the addition of liraglutide. Now, having done that, I want to move to the next part of the story, and you can see all of these samples. And what I want to get down to, and I hope that I do have the slides in order, because we tried to blend two sets of data here, and no, this is done. So let's now get on to the issue of dapagliflozin. And this paper was published in middle of last year, where we demonstrated that if you added dapagliflozin at 5 or 10 milligrams, you got a substantial fall in glycemic levels when you added to insulin and liraglutide in the background. So the liraglutide patients had already come down with their A1Cs by about 0.4, and by adding dapagliflozin, they came down by another 0.6. So a total reduction of 1% in HbA1c. Now, the trouble was that when we added DAPA, something unusual also happened. And that is, the glucagon concentrations went up. And this is a very important part, and it links up with Sundar's presentation on ketogenesis. And I'll show you the first data on ketogenesis in type 1 diabetics in a moment. So if glucagon is going up with SGLT2 inhibitors, which is opposite of what you want, how do these agents then exert a glucose-reducing effect? The answer is the induction of glycosuria is so profound that it overtakes any effect of glucagon in terms of glycemic levels. So it neutralizes that issue. However, the glucagon has an imprint because it's an important metabolic hormone. And of course, with it, what you see is an increased lipolysis and an increase in free fatty acid concentrations, which is the opposite of what you want. And then you have an increase in hormone-sensitive lipase, which will cause hydrolysis of triglyceride to give you free fatty acids and glycerol. And then the other important thing, and this is the first observation and the first description in a prospective study showing you what dapagliflozin and possibly other SGLT inhibitors do, in terms of ketogenesis. So you've got hydroxybutyrate rising by about 3 times over the baseline. But remember that the magnitude of this rise is still far below that of a DKA. This is not diabetic ketoacidosis, just ketogenesis, enhanced beta hydroxybutyrate concentration. And then with it, you also have got an enhanced acetoacetate concentration. Now, this is important, but in addition, what is also important is that urinary excretion of acetoacetate and beta hydroxybutyrate also goes up, and that tells you that the overall ketogenesis is increased in the body. Why that statement is important is because there was a paper from NIH which misled us about a year earlier, which sort of stated that the reason why ketones rise is because the kidneys are not clearing enough. Unfortunately, the reality of the data is what you see in front of you. Both urinary and plasma concentrations rise, and therefore the overall ketogenesis is enhanced by these agents. Now, so then we can conclude from that beta hydroxybutyrates were related to FFA concentrations, and FFAs, as you know, are the raw material from which ketones are built in the liver, and changes in FFA concentrations were also related to mean glucagon and mean beta hydroxybutyrate. So again, the role of glucagon becomes a very important one. And the other thing that I'm going to show you towards the end, which is very exciting, and this paper has just sort of appeared in Diabetes, Obesity and Metabolism, showing the liraglutide suppresses ketogenesis. And since I'm talking about triple therapy right now, with a combination of SGLT2 inhibitor, liraglutide, and insulin, clearly the ketogenic effect of SGLT2 inhibitors overrides the inhibitory effect by both by insulin at those doses and SGLT2 inhibitors. So that's important. Now, let's get on to then the last part of my talk. And I found this experiment really very exciting. It just excited me like a little child. So, I don't know whether anyone here is of my vintage in terms of diabetes and endocrinology, but when I started training in 1975 at the Royal Free Hospital School of Medicine as a senior fellow in endocrinology, we had no C-peptide assays. So how did we detect type 1 diabetes? And it was done clinically. And this is why clinical medicine always got to be respected. So what we used to do is to get our patients to take their insulin the previous night, come fasting the next morning without any insulin that morning, and we just used to sit them down in our examination room for the next 5 or 6 hours. Doing what? Testing for ketones in the urine. If they became ketotic, they were type 1s. If they did not become ketotic, they were type 2. And then we proceeded on treating them in that particular fashion. So using that model, and I was criticized by my fellows for doing that because they said, Dr. D, you're going to kill these patients. They're going to get ketoacidosis. You shouldn't be doing this. I said, no, I've done it enough in the past, and we live with this model. So we did that. And what you're seeing here is patients coming to our unit and sitting there for the next 300 minutes, right? 5 hours. And what is interesting is that these patients had been on insulin pumps, just getting their basal insulin. No bolus that morning. So we was trying to see as to how the glycemia would be maintained. And as you can see in the red line, which is the placebo line, they got saline injection as against liraglutide in the green line. Glycemic levels remained fairly constant. And this is what we are measuring all the time and feeling great about it, right? That glycemia is fine. Now glycemia in this basal state is determined by the skeletal muscle. Okay? So clearly the skeletal muscle is getting enough insulin when you're infusing it subcutaneously. All right? When you give liraglutide, glucose levels gently, they don't come down dramatically like insulin, but they're gently coming down. And you'll see in a moment what the mechanism may be. Now you measure glucagon, and the glucagon concentration in the placebo arm remains constant, as you might expect, but in the liraglutide arm, as I showed you earlier, steadily comes down. So this was a discovery. The GLP-1 receptor agonists suppress glucagon even as a single shot. Then, measuring free fatty acids, you can see free fatty acids are rising rapidly, steadily in the placebo arm, but they have significantly come down in the liraglutide arm, as you would expect, since liraglutide is suppressing glucagon. But the point I want you to realize from the point of view of physiology is that while glycemia was stable, lipolysis at the adipose tissue is still going on. In other words, when you're giving insulin pump therapy and feeling terrific, that blood sugars are fine, there is a possibility that lipolysis is still going on because adipose tissue is not getting sufficiently perfused at that level of insulin. Okay? Now, let's move in next to ketogenesis. So the first level of ketogenic substrates, acetoacetate. And you can see now the dramatic difference. So in the placebo arm, acetoacetate is rising, and in the liraglutide arm, absolutely flat. It almost looks as if we might have cheated on these results, but they are real. Okay? So now, beta-hydroxybutyrate, identical. So the first evidence that GLP-1 receptor agonists are actually anti-ketogenic and anti-lipolytic as well at the same time. And the other element that I want you to, again, thinking about the physiology, that clearly when you're infusing insulin and maintaining euglycemia through subcutaneous infusion of insulin, you are doing nothing to the hepatic metabolism in terms of ketogenesis. So this is the other important message to arise here, that we cannot live just in the world of euglycemia as measured by continuous glucose monitoring or whatever in the type 1 diabetic, because you could still be having inadequate perfusion of the adipose tissue and the liver. Okay? And then on to hormone-specific lipase, sensitive lipase, it did not change. And another new discovery that happened in this very simple paper is that ghrelin, the hormone that is secreted by the stomach to give you the hunger feeling and stimulates the hypothalamus to refeed yourself, that hormone is steadily rising in the setting of type 1 diabetes, but is completely inhibited with liraglutide. So what I've described to you now in this experiment, the last sort of most recent of our publications, is still not in print, it's still on the internet in diabetes, obesity, metabolism, is that GLP-1 receptor agonists, if liraglutide is a true representative, these drugs are anti-ketogenic, anti-lipolytic, and they suppress ghrelin, and this could be one of the mechanisms how they suppress appetite, because these drugs are known to reduce appetite and to reduce body weight. So, I would like to conclude then that I've given you a description of the real, I think I call it the evil state of type 1 diabetes, which is not controlled. And it's sad, because over 80% of type 1 diabetics today are not adequately controlled, and I gave you the mortality and morbidity figures from Lynn's paper. So in that setting, to begin to make some inroads into the treatment of diabetes, type 1, is extremely important and gives me a good feeling to be doing that. And the other element that I have not mentioned, and I think I'll briefly take the liberty of mentioning that as well, that SGLT2 inhibitors have been shown to be ketogenic, as I showed you a moment. They've also been shown to be associated with ketoacidosis, but what we learned from our studies was that when we reduce insulin doses, when we introduce these drugs, never reduce the dose less than 20% of the baseline. If you do, then you're asking for trouble, because insulin is the ultimate anabolic hormone, which I love and respect, and I've done so for a long time. And with that, again, with the last data on the novel discoveries on the actions of GLP-1 receptor agonists through liraglutide, I'd like to close my time, and hopefully we can use these drugs now in an intelligent way. But unfortunately, with all the intricacies that I mentioned, the use would have it confined to those who know their business and who know how to do it. And therefore, I think type 1 diabetics should be treated largely by endocrinologists and not others, because, as I showed you, it's a very difficult process. Of course, I mean, I'm sure I'm offending some people, but certainly it's my mission that we get them controlled perfectly. So thank you very much for your time and attention.
Much, sir. That was a very enlightening and a very stimulating talk. Type 1 is something that we all still fail to understand, and potential of GLP-1s and SGLTs in type 1 opens new avenues, especially with all these beautiful slides that you've shown. And the take-home message is certainly, yes, there are lots of things to watch out for, but like sir said, type 1 is not that easy. So you have to be very careful in doing all these, using these things. These are strictly off-label, so I think the clinical message should be, let's just watch out and see how the data emerges and then accordingly manage. Thank you so much, sir.
Thank you, sir. Thank you very much for enlightening us. So totally a new thinking which has come out of the box, which we never think of, and hopefully it is going to make the thing easier in coming time for treating type 1 diabetes. Thank you, sir. Thank you very much.
This being a sort of guest lecture, we will not learn questions. We are already running late, so we can have some personal discussion at lunch. But before I close, he kept my words, what I said, that he is an innovator and thinks absolutely unconventional. And what Dr. Medali rightly said, they don't reject anything useless because it is new. Make your own opinion and go with your own opinion and evidence. Thank you very much, sir. Great, sir.
Thank you, sir. I would like to now request chairpersons to present a memento to Dr. Dandona. Okay, now I would request Dr. B.M. Makkar to please present mementos to our chairpersons. Dr. Chawla. Dr. Jaggi. And Dr. Girish Kurana. Okay, now I would request Dr. O.P. Sharma to please say a few words.
After that, we'll have a vote of thanks and we'll please wait for some time.
When we planned this conference and sat down to make the scientific program, we had decided to cover medicine in toto, and we could succeed into that. We are not having the formal mementos, but we would like to express gratitude for all those who worked for us shoulder to shoulder. JK, can you come over here, please? And I would like this is a bonus. I never asked you to clap for him. His turn is yet to come. No, thank you. I don't deserve. I would request Dr. J.K. Sharma to kindly present a rose to Dr. Puneet. And now it's time for you to clap for him. I would request him to kindly present a rose to Girish, the master of the ceremony today. I would request him to present a rose to Mohit, who gave the gist of the conference as theme of the conference in the very beginning. Welcome. I would request him to present a rose to Dr. Anil Manchanda. And Dr. Vipul Gupta. And please don't think Please be here. Please be here. And he is in real senses, has increased the knowledge. So instead of doctor, instead of calling him Dhanvantri, I would like to call him Saraswati Putra and present him a statue of Goddess Saraswati. All of you, please come.
Hello. Now I'll request Dr. Manchanda to please come over and say a vote of thanks.
Yes. Yes, good afternoon, friends. It's my proud privilege to propose a vote of thanks on behalf of organizers of this CME. This year has been the year of launch of satellites in the space. So is our new satellite named Innovative Physician Forum has taken shape since March and was launched in this April. And in very short span of time, it grew to the number of 65 and still it is growing. And its activities has attracted the attention of even American College of Physicians Indian chapter, and they have joined us, and we are proud them to have with us on this CME. My special thanks to IPF, all the members who have participated for IPF, and American College of Physicians Indian chapter for joining hands in doing this scientific program. I thank especially to Dr. Anupam Prakash for joining in on behalf of ACP. Thanks to all those involved, especially my colleagues, in conceptualization, planning and execution of this mammoth meeting. Selection of topics and faculty, both Indian and international, was superb, and active participation is quite encouraging. I'm sure we have all become wiser in the field of medicine covered in select topics today. I especially thank Dr. N.P. Singh, Member Governing Council ACP and Vice President DMC for his guidance and help. I am grateful to our patron Dr. O.P. Sharma for his able guidance and telling us at every step the difficulties that we faced. I have no words to thank our Secretary General Dr. J.K. Sharma. He worked untiringly and he made this CME see the light of day. His hour to hour pains that he took for this conference made this conference success. I would like everybody to give good clapping hands to Dr. J.K. Sharma for his deserving work today. So, long life IPF, our association with ACP and other academic bodies, and I assure that in the coming time, we'll be keep on having these kind of academic feasts with time to time. And with this, I please invite everybody to have lunch with us. And I conclude the session at this point of time. Thanks.
So, 3 cheers for PPF. Repeat. Hooray! Repeat. Hooray! Repeat. Hooray!
Thank you, sir.